Three letters, three specialists, three diagnoses. None of them the same, none of them correct. For 2 years, her body had been sending the same signal in every language it knew. Medicine heard the words, but nobody understood the sentence. The body rarely speaks in a single symptom. It speaks in a language that requires the whole sentence to be heard. Her name is Amara. For this documentary, she's a fictional composite character inspired by documented clinical patterns. 28 years old, a graphic designer. The first symptoms was a rash across her cheeks and the bridge of her nose. It appeared after sunlight exposure. It faded and returned. GB referred her to Dermatology. The working diagnosis was photosensitive dermatitis, topical treatment, sun protection, observation. The rash improved. She went back to work. She assumed the problem was over. It wasn't. 3 months later, the pain moved somewhere else. Her fingers became stiff every morning, not for 5 minutes, nearly an hour before her hands felt normal. She returned to her GP and was referred to Rheumatology. The working diagnosis: early inflammatory arthritis, possibly rheumatoid arthritis. Anti-inflammatory treatment was started. 2 specialists, 2 diagnoses, 2 treatments. 2 separate stories that nobody at yet suggested might be one. 6 months later, the story changed again. Headache, persistent fatigue, cognitive fog, forgetting appointments, losing words halfway through a sentence. This time, our GP referred her to Neurology. Brain imaging showed no structural abnormality that explained the symptoms. The possibility discussed included migraine and stress-related cognitive changes. 3 specialists, 3 separate letters, 3 separate medical files, never read in the same room. Amara was not getting better. She was getting more diagnosed. And there is a difference. She returned to her GP, not with a 4th symptom, with a feeling. The feeling that something was wrong in a way no individual diagnosis had captured. IGP requested a broader review, not another specialist looking at one organ, a physician trained to look for systemic autoimmune disease, someone who could ask a different question. What if these symptoms were never separate problems? The specialist spent more than an hour reviewing the history. Then she asked questions that connected the pieces. Had Amara noticed increased ear thinning? Yes. Unexplained fevers, occasionally. Fingers becoming unusually cold or changing color? Yes. Foamy urine or other changes in urination? Sometimes. Chest discomfort when taking a deep breath, once or twice. Each detail had previously been assigned its own explanation. Stress, a viral illness, migraine, inflammation, but together they suggested something different. The specialist ordered targeted investigations: anti-nuclear antibodies (HANA), anti-double-stranded DNA antibodies, anti-dsDNA, complement levels, full blood count, urinalysis, inflammatory markers. The first result arrived, HANA strongly positive, then another, anti-dsDNA antibodies elevated, complement levels low, urinalysis protein detected. But the specialist did not diagnose lupus from one blood test. She interpreted the result alongside Amara's symptoms, examination, and the rest of her clinical history. The pattern was now pointing in one direction: systemic lupus erythematosus. The separate stories had become one. Lupus is an autoimmune disease. The immune system, which normally protects the body, becomes misdirected and produces autoantibodies that can contribute to inflammation and tissue injury. Because the immune process can affect multiple organs and systems, lupus can appear very differently from one person to another. Skin, joint, blood, kidneys, nervous system, lungs and heart. The difficulty is not simply that lupus has many symptoms. It is that the symptoms can arrive at different times, and each one can resemble a more common condition. A rash can look like a skin problem. Joint pain can look like arthritis. Headaches and cognitive symptoms can look neurological. Fatigue can be attributed to stress, poor sleep, or almost anything else. The disease is systemic. The healthcare system is often organized by specialty, and sometimes the gap between those specialties is where the mystery survives. Lupus does not always yield in the symptoms. Sometimes it yields in the distance between them. The diagnosis changed what happened next. Amara began evidence-based treatment and monitoring for SLE, including hydroxychloroquine as part of her management plan. Because lupus can affect different organs over time, treatment is not simply about controlling today's symptoms. It is also about preventing tomorrow's damage. And that is the first lesson. A diagnosis is not the end of an investigation. It is the beginning of targeted care. The second lesson is about patterns. One symptom can house dozens of explanations. But when several body systems are involved over time, the pattern itself becomes evidence. The third lesson is about the patient's story: hair loss, cold sensitivity fingers, fatigue, changes in urine, a rash after sunlight. None of these details was meaningless. The meaning appeared when they were placed together. And the fourth lesson is perhaps the most important. The positive ANA does not automatically mean lupus. Many people with positive ANA result do not have SLE. Diagnosis requires the whole clinical picture and appropriate testing by a qualified clinician. If symptoms repeatedly involve different parts of the body, especially when they persist, recur, or remain unexplained, the usual question is not, which symptom should I treat next? It may be, what connects all of these symptoms? Sometimes the breakthrough is not a better test, it is a better question. Amara still lives with lupus. There are difficult days, there are flares, there are appointments and blood tests, and days when the disease demands more attention than she wants to give it. But she described the diagnosis with one word: relief. Not because the news was good, because after 2 years separate explanation, she finally had one story. That is what a diagnosis can sometimes give a patient. Not certainty about every tomorrow, but a name for the thing they have been fighting. The human immune system is one of the nature's most sophisticated defense systems. For most of us, it protects quietly. We never notice it. But when that defense system turns inward, the investigation becomes more difficult. The answer may not be in the skin alone, or the joints, or the brain. It may be in the space between them. The investigation continues. It always does. In the next episode of Medical Mysteries, a 35-year-old man collapses during a morning run. No known heart disease, no family history, no warning. The cardiac team finds nothing obvious on the standard test, but one exam level mentioned at admission has been quietly abnormal for years. It appeared on routine health checks. Nobody ignored it. They simply never asked why it was there. If you enjoy this documentary, please comment, like, and share. Subscribe if you have not done so. See you in our next episode.